Now let me welcome Dr. Amarnath Reddy sir to give lecture on greater and lesser occipital nerve interventions. Welcome sir.
Good afternoon, everybody. I thank Dr. Gautam Das sir and the scientific committee of ICRA for giving me the opportunity to this academic feast. And I don't take much time. I'll try to finish off in time or maybe less. My topic is regarding the occipital nerve intervention. And greetings from Hyderabad. This is a hospital where I work. It's a slide changer. Okay. So just before getting into the block per se, we just know what are the common indications for occipital nerve interventions. As we all know that occipital neuralgia is one of the most common indication for occipital nerve blocks. Apart from that, there are so many other interventions, so many other conditions where this block is of very much useful, like cervicogenic headaches, even in conditions like migraine headaches. Yeah, and most importantly, even in it works sometimes wonders in cluster headache where it is refractory to most of the other medications. And also we see sometimes even in post-dural puncture headaches, even if the patient is failed with the epidural blood patch, then this comes for rescue for doing bilateral occipital nerve blocks. And also we see in whiplash injury and even in osteoarthritis of the neck, these blocks can be of helpful because sometimes this can cause osteophytic compression of the occipital nerve causing occipital neuralgia. So next comes to the definition. What do you mean by occipital neuralgia? The IASP definition of occipital neuralgia or Headache Society definition is defined as unilateral or bilateral episodic shooting or stabbing pain in the distribution in the posterior part of the scalp in the distribution of either greater, lesser, or third occipital nerve. It's not just greater occipital nerve. It can be either of the three, but usually 90% of the cases, the greater occipital nerve is the main contributing factor. And in less than 10% of the cases, it can be either due to lesser occipital or third occipital nerve. And in simpler terms, occipital neuralgia is defined as neuropathic pain arising from either GON, TON, or lesser occipital nerve. And in fact, this has been described almost like 1.5 centuries ago, like in 1820 by Benito, a Spanish surgeon. Just briefly, I'll touch upon the course of the greater, lesser, and third occipital nerves because this actually helps us in identifying the location and guiding us the proper guided interventions, especially when we are using the ultrasound. As we all know that GON arises is the C2 dorsal arises from the C2 dorsal ramus. Once it comes out between the C1 and C2, it wraps around the inferior obliquus capitis muscle and pierces and it lies between the semispinalis and the obliquus capitis inferior muscle, and it pierces the semispinalis before becoming superficial. It lies in the trapezius muscle and pierces the tendinous junction and becomes superficial, lying medial to the occipital artery and supplying the posterior part of the scalp, predominantly on the medial to lateral 1/3 aspect of the posterior aspect of the scalp. And coming to the lesser occipital nerve, it arises from the superficial cervical plexus from the ventral ramus C2, C3, and it wraps around it comes posterior to the sternocleidomastoid and pierces and becomes superficial, supplying the lateral aspect of the scalp. And similarly, third occipital nerve, it's actually the superficial medial branch of the C2, of the C3, and it innervates the C2, C3 joint and also supplies the medial aspect of the scalp. I just want to touch about the trigeminal-cervical complex. we all know that we often give occipital nerve blocks even for atypical facial pains and also for cervicogenic headache pains. The rationale behind is the convergence of the trigeminal and the C1, C2, C3 nerves in the trigeminocervical nucleus, in the caudal aspect of the trigeminocervical nucleus. So that is the reason even in trigeminocephalgias, we often do the occipital nerve blocks for managing refractory neuropathic pain. And also, as I mentioned, cervicogenic headache also arises, is a referred pain coming from the back of the neck and referred as a headache in the scalp. And GON compression, greater occipital nerve compression, as we know the course of it, the course of the nerve, we know that it can get compressed at any of the 4 points in its course before it becoming superficial. The most common site of compression is at the level of the aponeurotic junction of the trapezius, and also sometimes at the arising of the nerve underneath at the inferior border of the obliquus capitis inferior muscle. And this forms the rationale for doing hydrodissection and also for dextrose prolotherapy. And similarly, the lesser occipital nerve can get compressed at the aponeurotic junction. And this is a beautiful cadaveric dissection showing the lesser and the greater occipital nerve, and you can see a connection in between. So sometimes that's the reason why we often combine both the greater occipital and the lesser occipital nerves for managing occipital neuralgia, though we often believe that it's only the greater occipital nerve, because sometimes because of the connections between the two nerves, it can cause patchy block. And I'll just touch briefly about the suboccipital triangle, because this is also the very important structure lies there, the vertebral artery. Sometimes while doing an ultrasound scan, we often go a bit proximal and see the C1 nerve, which is actually the suboccipital nerve, thinking as a great occipital nerve. That is the reason always having a proper zone anatomy is very important, because the vertebral artery stays close by to it. And C1 nerve is predominantly the motor branch. It supplies all the rectus, obliquus capitis inferior, superior, rectus capitis posterior major and minor muscles. And third occipital nerve is also very easy to block, and it's quite superficial. It arises, it lies at the junction of the C2, C3 facet joint, and even on fluoroscopic guidance, it is easy to block by hitting at the junction or at the superficial aspect of the articular pillar. And the risks, I'll just skip, as we all know that it's quite a safe block with very minimal complications. Mostly, like, we often see that the patient can become sometimes, while doing bilateral occipital nerve block, can have a vasovagal syncope. So always be ready to have a resuscitation equipment when doing these blocks. And traditionally, we have been doing, before the ultrasound era, using the landmark guidance, because as in the superficial and the distal aspect, it is very superficial and very easy to palpate the occipital artery. And as we know that anatomically it lies medial to it, we just feel the occipital protuberance go 2 centimeter lateral and 1 centimeter down and palpate the artery and inject around the medial aspect of the artery in a fan-shaped manner. And similarly, and if you draw a line from occipital protuberance to the masseter tubercle, masseter process, at the lateral 1/3, we can block the lesser occipital nerve. But being a pain physician, we have to be, we are more of a precision interventionist. So we need to always do perfect blocking, because sometimes we often know that anatomical blocks require larger volumes, and also sometimes there is some failure rate of 5 to 17%. So this is the reason with ultrasound guidance, the success rate is close to 98 to 100%, depending upon the user experience. And position, it can be done either in the supine, in the prone position with the head flexed, or even in the sitting position, depending upon your comfort level and also the patient comfort level. I usually do most of my nerve blocks in the sitting position, as it becomes easier for the better ergonomics and patient comfortness. But only make sure that sometimes if the patient is having giddiness, have an IV lens ready with the IV lens secured. And this is the main important zona anatomy we have to understand while doing the greater occipital nerve block. This is the boat-shaped inferior obliquus muscle, But sometimes identifying the C2 bifid transverse process might be difficult. So why usually, like, my simple trick is just to put the probe towards the mastard process and try to look for the obliquus captus inferior muscle rather than struggling to find the bifid C2 spinous process. Because in the volunteer scanning, it might be much easier, but when in the real patients, you might really struggle to find out that bifid spinous process. And once you see, you can see most of the time a hypoechoic structure surrounded by a hyperechoic connective tissue, that is usually the greater occipital nerve, and sometimes you can see a pulsating veins beside it, vascular structures beside this. So try to use the Doppler before doing the dissection, and you can either come from medial to lateral or lateral to medial. There's no clear consensus on which is best or better. It's up to the user experience. I usually prefer to come from medial to lateral. The advantage is sometimes I even can block the third occipital nerve during the course while entering into the plane between the semispinalis and obliquus inferior muscle. And of lately, people are talking more about dextrose prolotherapy, but when I looked at the literature, there is no clear consensus of the concentration what we use for dextrose prolotherapy, and it ranges for anywhere from 5% to 22.5%, and in this, they use 15% dextrose with 2% lignocaine. They use around 3 cc at each nerve, but even the volume varies so much that in the recent article by Dr. Stanley Lamb, he used almost like 20 cc of 5% dextrose on each side. You can see the volume difference. And his technique is a bit different. He uses an in-plane approach at the distal aspect of the occipital, greater occipital nerve. And coming to the pulse radiofrequency ablation, again, most of the time we often do the pulse RF refractory occipital nerve blocks, or even the blocks last for a shorter duration. Again, there is no clear consensus regarding the duration of cycles, and also the duration of the number of, the length of the duration we need to do the pulse radiofrequency. Usually it ranges from 120 to 360 seconds. And usually most of the studies, what I have gone through, they have shown the results of anywhere from 3 to 6 months improvement in the pain scores. Yeah, this is a recent systemic review done at at the hospital where I work, Toronto Western Hospital, and they published last year. They shown that the quality of evidence is very low quality evidence on the analgesic benefit between the pulse RF of GON and in chronic migraine headaches. So we need better quality studies to have a clear consensus on this. And there's another study which shows that rather than going for a repeated occipital nerve blocks with local anesthetic plus or minus steroid, pulse radiofrequency gives a better, longer relief. And coming to the role of Botox, everybody knows that Botox works by muscle relaxation and also having nerve block signaling. Again, there is some evidence to show that Botox has its role, especially in relieving the pain if due to the muscle spasms, but not in all the cases. And again, the number of units Botox can be used varies depending upon the musculature, and also it ranges from 5 to 100 units. Some people usually directly inject Botox into the occipital, obliquus captus inferior and also the semispinalis muscle, and all. Some people use at multiple points where it is the inferior, greater occipital nerve at the distal aspect of the greater occipital nerve and the distal aspect of the lesser occipital nerve. And again, recently the interest is growing towards peripheral nerve stimulation for occipital neuralgia. Again, this is a very expensive procedure, and I know we don't have any much equipment in companies available here. The one which we used to use in Canada or even in US is the Sprint system, which is quite helpful because it negates the need for putting a spinal cord stimulator or going for a spinal cord stimulator for refractory occipital neuralgias. And even the evidence is not great for those things too. And cryoneurolysis of greater occipital nerve. I don't have much experience on I don't have experience on doing on this greater occipital nerve because again the results shows that it's only having short-term benefit, and if you see the size of the probe, it's quite big and it's quite uncomfortable for the patient. So it's better to do a pulse RFA or even do a diagnostic, local with steroid. And like PRP getting into everywhere, I just looked into the role of PRP for greater occipital neuralgia. Some claim that PRP is a magic drug, it works wonders, but in this, when I looked at the literature is very scarce, and even there is very low evidence for the use of PRP in occipital neuralgia. So overall, in the systemic review, in the last year I checked, this is the systemic review for meta-analysis for occipital nerve blocks. They show that occipital nerve blocks under ultrasound guidance with local anesthetic and steroids have level 2 evidence ranging efficacy from 6 weeks to 3 months. So it depends whether you want to repeat the blocks once again when the patient comes back, or you want to try for a pulse radiofrequency ablation, and there's no clear consensus yet, and it's up to the end user preference. And the chemical neuroablation, again, there is no consensus regarding this, though it has chemical neuroablation has been used in many other neurolysis procedures, but coming to the greater occipital nerves, there's no consensus for the use. I did look at only 2 studies, that too, one is a case report and one is, those 2 are the case reports. They found relief up to 9 months. Yeah, in summary, occipital nerve blocks are one of the effective treatment modalities for occipital neuralgias and very easy to perform even in migraine conditions. But coming to the choosing the kind of intervention, there's still a lot of evidence gaps. If you want to go for a continuous thermal RF or even a pulse RF, there's no clear consensus as of today. That's what I can say. And ongoing research and high quality studies are yet to come to give a clear understanding on the further interventions, what we can choose. Thank you for your patience hearing.
Thank you, sir,
And
for your wonderful
I would like
presentation.
to, being a part of the organizing committee, I would like to invite you all to the ISSP Con, 40th ISSP Con at the beautiful city of Hyderabad in the month of February. Welcome you all. Thank you.
Thank you, sir. One thing I want to add, because for all the pain management, you have discussed everything, but there is also importance for the awake craniotomy and for the reduce of the pain during the operative period.
Yes.
That is a separate issue, but this
Awake
is
craniotomy, we need to cover all the scalp blocks, almost like 7 blocks on each side.
Actually, one of the part of the scalp block is the greater and lesser occipital block. It is very important, and also to reduce the amount of the analgesic perioperative period. If you give the greater occipital nerve blocks associated with the other peripheral scalp blocks. Okay, thank you, sir.
Thank you.
Thank you for the impactful lecture, sir.